going to be worried. So you really need to put all this stuff into perspective, because a lot of things can happen to the ovary. You may get simple cysts, you may get other things in it, you may get disease around the ovary that may mimic ovarian disease and so forth. The first thing, as you're doing your exam, as Mary suggested, start abdominally, make sure there's no obvious large masses, but you can see the ovaries best with a vaginal scan. And make sure you're really looking at the ovary, which is, I could suggest the ovary is visible. However, that's not, because we can see we've got mimickers. And a real time makes it a lot easier. It's in a bowel loop, it's in peristalsis. Remember, you've got a probe there. Push with it. A bowel loop should compress, we should start to peristalsis. If you have vessels, sometimes color will help you. It makes a pretty picture. You don't really even need color. You just need to sharpen the gain a little. See the vascular flow, such as I showed you a couple of days ago in that portal vein. You can read it. Usually it's venous flow that's going to get you into trouble and mimic an ovary. Also the probe, a vein will collapse. You do it all the time in the legs. The same thing is true in the adnexa. This is the most problematic case. That really does look like an ovary, and it's right by the iliac vasculature. But you're pushing, as we saw earlier today in Dr. Dubilay's talk, with the ectopic moving away from the ovary. Well, that thing stays with the uterus. This is a small fibroid sticking off the edge of subserosal fibroid. Look harder to find the ovary. The ovary undergoes lots of changes, both normally and normally. In terms of the discussion and terminology, is to separate physiologic and functional, because the names that we give these cysts are similar. Dr. Netter, my good friend, the cycle. Ideally, I'd like to scan at the beginning of the cycle here before you have any dominant follicles or anything in the ovaries, right after your menses. Good time also to look at the endometrium. I ask every woman 2 questions when I do a pelvic exam. If you're pre or postmenopausal, I say, when was your last period and are you on hormones? And I want to know the answers to that to interpret what I expect to see. So ideally, I'd like to scan a patient here, but if she comes up here close to day 14, I would certainly expect to see a follicle, anything more than about 25 millimeters. Simple, except sometimes right around day 14, I might see that little cumulus, as we see here on Dr. Netter's picture. That's where the oocyte lives. And if I see that and I'm around day 14, it's fine, it's normal. The problem is after ovulation, when you develop a corpus luteum, and you almost shouldn't use the word cyst. You can see from that, does that look like a cyst? Well, hardly. And it's smaller than the follicle, but it looks solid, just like the diagram does. And furthermore, if you put flow on it, it has a lot of low resistance. That means a lot of flow during diastole, just like a bad disease called cancer could have. However, there's no flow in the center. This is a young woman. It's the time of her cycle where I'd expect a corpus luteum. And if I saw that and I was shown this case, I'd say, most likely it's a corpus luteum. If I had to, I might want to rescan her in a couple of months right after menses to make sure it went away. In our hospital, we do not routinely do that unless the patients are back for some reason, because they're so visible on every woman if you scan them at the right time of the cycle. The confusion arises when you start getting problems with your cycle. You may fail to ovulate, or you may fail to involute your corpus luteum, in which case you can have complications, i.e. a persistent follicle. The reason we use the word functioning now is because of the hormone elaboration. There's a lot of estrogen in the neighborhood when you have a functioning follicle. And this woman would have failed to ovulate, would fail to involute this follicle. I'll talk about that more in a minute. The corpus luteum, as we see, can hemorrhage. It may even rupture, and it's associated with testosterone production. And these women then may have trouble with their cycle because they're resetting their clock because of hormones, estrogen and progesterone. So if I see a case that looks like this, where I see what looks like a simple cyst, but it's greater than the 2.5 centimeters, I would call that a follicle. If I see what looks like a complex cyst, knowing the appearance of what hemorrhage looks like, I would call this a corpus luteal cyst. In this case, I would call this a third type of functioning cyst, where I see multiple peripheral large follicles. Those are thecal lutein cysts in the environment of increased ATG. If you'll excuse me, I have to apologize because I set this lecture up because we're having computer problems, but this is the wrong form of this lecture. So I'm just going to get out here for 1 second, and I'm going to try to get onto the correct lecture. I apologize. Whoops. Well, let's see. happens when you lend your computers to people. Okay, I'll go back. Maybe I didn't save it. We'll blame myself. Okay, come right back to it. Okay, because I was doing something else, and well, we'll see. It'll be okay. Not to worry. Okay. Come on, baby. Oh, where's my friend Jones when I need him? Oh, that's right up there. Okay. Okay, so I'm just going to skip right ahead. Okay. So fecal lutein cysts occur in the environment, the hormonal environment of increased HCG, and we can see increased HCG due to either a woman, used to be in my old practice years ago, in a woman with gestational trophoblastic disease, moles, choriocarcinoma. But today we also have to consider so many women are being given HCG in their effort to get pregnant, have increased HCG on board, or if they get pregnant, they get multiple pregnancies. Each placenta elaborates HCG. And we've already heard that the treatment for this is waiting, because as the HCG comes down, ultimately these cysts will get better if it's due to hormonal regulation. Obviously, with gestational trophoblastic disease, the underlying condition has to be treated to get rid of the HCG. Don't forget to look around the neighborhood for ascites, for pleural effusion, pericardial effusion, with hyperstimulation syndrome. Usually these cysts are at least very large, approaching perhaps 10 centimeters in size. Now, ovarian cysts or other conditions around the neighborhood, a lot of non-neoplastic conditions, and finally neoplastic conditions. You may have postmenopausal cysts, you may have polycystic ovaries, you may have things outside the ovary that can mimic the ovary, if you will, and of course you may have hemorrhagic conditions, endometriomas, or the hemorrhagic cysts such as you would see with a hemorrhagic corpus luteum. So let's start with a postmenopausal woman. What do I do when I have a postmenopausal woman and I see a small, what looks like a cyst in her ovary? The first thing I would do is put color on. Make sure that ovary is avascular. Look very carefully at it. Make sure it's avascular. We know from various articles in the literature, and in the literature they're using about 5 centimeters as the cutoff point, under which I perhaps wouldn't worry. Most of these cysts, in truth, are 3 centimeters and less. It's really unusual to have a cyst that's approaching 5 centimeters. That's simple in a postmenopausal woman. Most of them are small. But the good news is, if you look at the literature, cancer is really rare. And if you follow these, about half of the time, they will disappear. My suggestion, as you're looking at these women, and I will use that number because the literature does go along with it, but in practice it'll be much smaller than 5 centimeters. Follow these maybe every 3 to 6 months for a year, maybe then every 6 months extend it out for maybe 2 years or so. And if it hasn't changed, I would be very reassured. Good things stay the same or get smaller. Bad things get bigger and get worse. Now, what about polycystic ovaries? Well, we know there's a sort of an appearance that we have in our mind. The ovaries tend to be somewhat large. They're more spherical than a normal ovary would be. And the rules that are used to characterize these ovaries are no follicle greater than a centimeter, okay? And usually around the periphery, at least 12. And they kind of resemble, if you will, a string of pearls around the periphery of the ovary. These ovaries are often hyperechogenic, and I'll emphasize they have vascular stroma. And the reason we often scan these women isn't so much for the diagnosis, because clinically it's pretty well known when women have polycystic ovaries based on their clinical and endocrinological workup. It's the hypersensitivity to ovarian stimulation. As these women try to get pregnant and are manipulated, we often will follow them and look at their ovaries to make sure they're not being hyperstimulated. Here's an example of a woman with polycystic ovaries, somewhat large and spherical. I draw your attention to how much color there is and a lot of Doppler flow. Now, if I gave you 100 women whose ovaries had peripheral follicles without a dominant follicle, would you say 100 times it would be polycystic ovaries? Not really. The most common cause for an ovary to look like that is not polycystic ovary. Notice that's an avascular ovary. It's a woman on oral contraceptives who is not ovulating, although in most of those women, the ovary is more almond-shaped or elliptical, and here it would be rounder. But, you know, there are exceptions sometimes to those rules. Dilated tubes, well, we can see from Dr. Netter's diagram that the ovary is often encompassed or embraced, if you will, by a dilated tube. And we can see that on the ultrasound as well, particularly at the fimbriated end, which is often larger than the more proximal portions of the tube. Notice how it typically folds upon itself. 2 examples. So it's that configuration, that folding upon itself, embracing, as we can see here, the ovary. And that's really what you want to look for. Notice also in this woman there are little folds. Be careful about using the word mural nodules here, because you say mural nodules, I'm going to think something really bad. But tubes, especially if they've been infected in the past, often have these prominent flecal folds. And that's just what they are. They're not mural nodules, so don't use that word when you don't mean it. As the tube becomes filled with complex material, it becomes much harder to see the ovary. And when would I see the tube filled with complex material? Well, with something like PID or with blood in the tube. So I'd like to know a little more about the history, please, to help me decide which of those 2 it would be, because clinically, pus and blood act quite differently from a clinical point of view. Now, para-ovarian cysts or paratubal cysts are common. They are embryologic remnants. And the good news is that complications are very infrequent with respect to paratubal or para-ovarian pathology or conditions. So if I see something that is a paratubal or para-ovarian cyst, knowing it's an embryologic remnant, and the woman's asymptomatic and it looks simple, it's not going to go away. So I'm not going to worry about it. It'll be here if I scan her next month or 2 months from now. The main thing is, when I look at something, to know, is this part of the ovary? Because from the size here, if it was ovarian, I would probably want to follow this woman. Whereas if it's extra ovarian, I would suggest it's something I wouldn't worry about. So what am I going to do? I'm going to, again, probe with the probe, and here very nicely, I think you can see that we are separating these 2, and therefore this becomes a para-ovarian cyst. Nothing to worry about. It's small. I certainly wouldn't get anything worried about this until it's at least over 5 centimeters. That's usually, again, that cutoff. And then it would really, sometimes they can torse, but it's quite unusual. So relax when you see something that's para-ovarian. Now, here's another patient, very clearly a separate, simple-looking para-ovarian cyst. Let's say in this patient, however, I'm starting to look, and now I see these, they look like septations. Well, is this para-ovarian? Is this something I should worry about? Is ovarian? It turns out this is something called peritoneal inclusion cysts. And as we have better transducers today and do more and more imaging, particularly on ultrasound, we can see these fine septations that often, and sometimes even more than fine, they can be quite pronounced, in these things called peritoneal inclusion cysts. What are we talking about? We're basically talking about pelvic adhesions in some women. For some reason, women who have a history of pelvic surgery or inflammation, many of these people, their peritoneal cavity, for some reason, exudes fluid, and these women want to trap that fluid and wall it off in the way of forming adhesions. And it can be worrisome sometimes by looking at it. The trick to making this diagnosis is, first, you want to know the history, that there's been previous surgery or inflammation in that patient, and you want to find the ovary. So here are 2 different patients. This woman has something bad. This is a peritoneal inclusion cyst. I draw your attention to a couple of things here. If this was shown in its entirety, you'd appreciate that this is a roundish lesion. Tumors tend to be round or spherical. This, if you took those lines away, is much more passive, like ascites would be. And so that is an important clue. And then, looking further at this woman, we were able to find her ovary. If I couldn't find her ovary, I would get an MRI looking for her ovary, because the last thing I want to do is say, I'm worried in this woman that this could be a neoplasm, which would start spinning the wheel, ending up in surgery. It would be tough surgery because she's already got adhesions, and what will happen? She'll get more adhesions. A lot of these women end up with bowel obstruction, so you want your hands off on these women if you can, based on the history, finding the ovary and looking and noticing it's really relatively passive fluid. Now, I'm sure you recognize this, right? What am I dealing with? What? Endometrioma, did I hear you say? I hope so, okay? Because this is an endometrioma that we're seeing here. This is classic. Notice, however, that sometimes with an endometrioma, the echogenicity of the blood can be very much similar to the peripheral echogenicity that we're seeing of the parenchyma. But here I can see follicles. Here I can see follicles, obviously at fluid debris level, so I'm not really worried about that. That one I would worry about yesterday, today, tomorrow, because I was worried. She went to surgery, and the pathologist, who never is wrong, it's only after the fact of surgery, assured me that was an endometrioma, but that is clearly the exception. So the ovary, most women who have endometriosis, the most common appearance on ultrasound endometriosis is a normal scan. It's only when you develop an endometrioma within typically the ovary that you see these echogenic masses that typically have these homogeneous low-level echoes. Now what about this? That doesn't look the same as the endometrioma that I showed you. Although it is avascular, it's much more heterogeneous. And of course the history helps too. This woman came in with acute pelvic pain and she was mid-cycle, and I think you would suggest at that point, because it's avascular, that this is probably a hemorrhagic cyst and with the acute episode of pain. We know that these are transient, so if you can follow these for a few months, it should go away. Acute clot, we can see here a nice example. As clot resolves, it undergoes an evolution, if you will, in which case it becomes, and there it's difficult to know how to describe this, but I would prefer the words reticular-like material, spongy, cobweb, that's a good adjective. If you're going to say septations, say fine septations without vascularity in the septations, because you're describing something that should be avascular, an evolving blood clot, and that's quite important. Now, sometimes clot can retract and look a lot like a mural nodule. If you put color on here, there should be no flow, but I would be a little more concerned about this. Obviously, I'm going to follow both of these cases. Now here you look and say, well, you know, I can't tell, is that a mural nodule versus clot? The first thing you should want to do is to turn on color, because if it's a mural nodule, it ought to have some flow. Well, there's no flow there. The next thing I would do is what we are doing here. I know it looks funny, but I love to probe with the probe, you know, and you can see it's very passive. It's like jello or jelly. It jiggles, you know, and a tumor, which we see here, doesn't jiggle, right? That's a solid mass in there, and that's not jiggling, whereas that is. So I certainly would follow this, but I'd be much more inclined to think that that is a blood clot. Now, cancer does a lot of bad things. We all agree with that. But one thing it tends not to do is bleed. So if you see any of the pictures that look like what I'm showing you that suggests it's blood, please follow that patient. Don't send her to surgery. Don't get worried, because if you follow it, it should go away. If it looks like this and you put color on, I can almost guarantee you there'll be flow in that, in which case you'd be worried right away. And there were other findings in that woman. So here I have both a hemorrhagic cyst and an endometrioma. And because of our time constraints, I'll let you all make up your own minds, but I hope you will conclude that the homogeneous material there was the endometrioma. The hemorrhagic cyst was more heterogeneous. It disappeared as we followed this woman. She went to surgery for the endometrioma. We don't send women to surgery for endometriomas because we're worried about cancer, but they have clinical symptoms that warrant them to go to surgery to have these things resected and removed, because they don't go away on their own. Now, what about these two cases? Something funny going on in both of them. And I think if you look carefully, and it always helps, one thing you're not going to see are labels on your pictures. It helps to see labels, doesn't it? Well, that, I guess, is a longitude. I mean, that's a left ovary there, right? Okay. So we're seeing in two patients masses. And I want to draw your attention to the location of these masses. Each of these women came in acutely symptomatic. This is a torsion due to a hemorrhagic cyst with a clot in it. And we can see the location of that here. And this was picked up by one of our residents at night, and the bladder was totally empty here on the sagittal scan, and that was due to a dermoid. Now, what is peculiar about this? The location. How often do you see an ovary sitting in front of the uterus? The ovary belongs to the side. Just like in a man who torses his testicle, you look for asymmetry in position. The same thing is true in a woman, and I think that's very important. Here's two more examples for you. In this case, notice here, the right ovary was off somewhere here. There's a leading edge here. The uterus is here. But this is the left ovary coursing into the right adnexa. And here's another patient, the right ovary and the left ovary. You see where the uterus is. How often have you seen both ovaries to one side of the uterus? This is the time you might see it. So in these cases, the torsion caused the ovary to go deep in the cul-de-sac and even to the opposite side. Interestingly, in both of these people, their symptoms are where the twist occurs in the tube, not so much where the ovary ends up, but at the site where the torsion actually occurs. So we know about torsion here. I emphasize it can occur in young women. One of the things I think that should be emphasized is that you may have blood flow because of a dual blood supply to the ovary, and I really emphasize the unusual location of these ovaries. Here we can see from this diagram how the ovary does have a blood supply coming in from medial and lateral. So if you torse one portion of this, you may preserve flow to the ovary. Here's an example where a patient just has ascites, no torsion, but I draw your attention to the straight pedicle here that we're seeing in the region of the broad ligament, and it should be fairly straight, just like the cord is fairly straight. This was a study done by Rusty Brown when he was with us. Unfortunately, I don't have a clip, but I think you can appreciate that's concentric rings, like a pinwheel, if you will, and this is a woman who has a torsion of her ovary. As a matter of fact, this is that same woman, and this is deep in her cul-de-sac, unusual position, big ovary, tender to transducer palpation, and look what we have here, both arterial, and this ovary did not read the literature because it theoretically shouldn't have venous flow. But it just shows you may have a torsion a little tighter, a little looser, a little tighter, and you may preserve even venous flow. And if you do have this flow, this is truly an emergency. You want to get this patient to surgery because her ovary should still be viable, and it was. If you wait till there's no more flow, and the ovary looks, awful, well, that's because it's necrotic and dead, and you send it to surgery, and what do? An oophorectomy. Here, that ovary was saved. So just bear in mind, you may have flow to an ovary. What about this? What do I do in a case like this? I see a few little punctate things throughout the ovary. Here, I see more around the periphery. I make this an analogy in its appearance, but not in its relationship to worry, to what looks like microlithiasis in the testis. But in this case, we don't really know what these are. People are calling these calcifications. Some people think it's hemosiderin. The bottom line is we do not worry. It's not like in a man with microlithiasis where we worry. We do not worry. Now, if it's very dense and a lot in the periphery, you might want to think about looking at something like a CA-125 or make sure the woman doesn't have a history of some breast cancer, colon cancer, because very occasionally you can have tumor with calcification around the periphery of the ovary. But those linear kinds of appearances are very unusual. But we see those little ditzels all the time in the ovary because we have good transducers. So the bottom line is we don't worry about that. Now, what about ovarian neoplasms? Notice it's at the end of the talk because in the discussion of do we worry or not, we have a lot more, fortunately, not to worry about. But we don't want to forget about neoplasms. And it's a very sad commentary, I think, to look at this information and to realize that since 1993, a decade, we have not helped in the mortality of saving these women's lives. We just still are not doing a great job. When we think about ovarian neoplasms, we can think in terms of germ cell tumors, METs, and primary tumors. And for the sake of time, we're going to limit it to this. It's important to recognize what dermal ones look like because most of them look like a variation on a pretty typical theme. And that theme is, and knowing what's causing the echogenicities and the lucencies, a lot of people call this fat, and that's not fat. That is hair in a dermoid, and it has gradual acoustic shadow. It's like a hairball. You ever have your cats, you know what I'm talking about when you say a hairball. Well, that's what that looks like. And the sonolucent material is actually liquid sebum. It's like taking Crisco or butter, heating it up to body temperature, it liquefies. It's not in a cellular format the way fat is elsewhere in your body. So that's the liquid that we're seeing. And if you don't believe me, we have a nice CT there to compare it to. right? Classic for a dermoid. They should come out because they can torse. They're not going to go away. They may be symptomatic if they keep getting larger. And very, very, very rarely they can have malignancies associated with it. Now, also, you're never 100%. Here's a dermoid. When I looked at that, I said, if that's not a dermoid, I'd eat it. And I would serve this on a tray with sesame seed bun and pickles and relish and all that kind of stuff, because it looks just like a dermoid. So you can never be 100% sure. And also, dermoids have variations. I showed you classic dermoids, but here we have a cyst. Now those are neural nodules, okay? They happen to be vascular, but at surgery, this turned out to be multiple dermoids within a cystic structure. So we call them dermoid plugs. It's also known as Rokitansky plugs. So you know Rokitansky was a pathologist if he related to both the gallbladder and the ovary, and he was a pathologist. What about this? It's very bright, very sharply defined. The shadow is different. It's not that gradual shadowing. What would I expect to see then if I was to take a film? I would see calcification from a bone or a tooth. Looks different. It's much brighter. What about this? These are the kind that you have trouble with because they kind of look like bowel. You know, they're hard to see, and you often can underestimate their size. And it's really that big, and that's probably the hair. I'm not sure what all that stuff is. It's a lot of echo. You can have very complex fluid with dermoids. And what about this? Well, I call that a bad hair day. That's when your hair is flying all over the place. Some people have termed that the spaghetti sign, another feature that we sometimes see with dermoids. And here, if you have a patient that has a, quote, mass palpable and you don't see it, and you've done abdominal vaginal scan, you don't see one of the ovaries either, think about a dermoid. And clips can sometimes help. Here's a clip done. I still think that's hard to see. Maybe I see something. But given the choice of two clips, which one here do you think shows you more convincingly a mass? I think we would all agree. And the difference is technical in that here I am doing a sweep panning motion with my probe, and here I am pushing over that area of suspicion. I can compress the bowel around and move it relative to that obvious now mass, which I think is harder to see. Metastatic tumors are often solid bilateral. If it comes from the GI tract, we call it a Krukenberg tumor. Dr. Netter agrees. They're often more solid than the primary tumors that we see in the ovary. And sometimes you'll see a solid mass, as we see here. Notice the shadowing. I wish there was, from within the mass, I wish there was a little more attenuation of sound here, because if I thought that was from an ovary, and it looks like a fibroid, and especially if I saw ascites, I would think of Meg's tumor, which is due to what? Meg's syndrome, what would that be? An ovarian, like the word fibroid. Fibroma, benign tumor, often associated with ascites. Be careful, there may be lookalikes. That could be an ovarian fibroma, certainly, but maybe it could be a pedunculated fibroid. Well, maybe. By pushing again, that tends to move with the uterus. And another maneuver that I like to do is put blood flow on and see if it's supplied from the uterus, which I think it is in this case. You can see those vessels. So this is just and find another ovary in another location. So then this is going to be just a pedunculated fibroid. So there are things that can mimic masses that are, you think is the ovary, but not. The typical appearance that we see for ovarian cancers or true neoplasms are from the surface epithelium, benign, borderline, malignant, we can see here, and that looks just like the picture that we saw, very complex. This turned out, interestingly, to be benign, so you really can't tell benign or malignant. Obviously, you're not going to let that sit in the patient. Benign cystadenoma. Now look at the next case. Benign cystadenoma, showing you the variation that we can have here. But notice that's 11 centimeters. You're never going to sit on an 11 centimeter, even if it's simple, because it's too big. 5 centimeters sort of the cutoff. Getting back to our postmenopausal woman here, we can see when we put blood flow on this woman, and this is a very important case because now we see a little bit of blood flow in that postmenopausal patient with a disturbing blood pattern. She's 65 years old. This is not a corpus luteal cyst. This is what we worry about. Yes, we should worry. That's the time you're going to save a life, stage 1 cancer. But if you don't put color on it, look very carefully. We know cancer occurs postmenopausally, so it's important at that point to really use your color and help you. What we do in our lab in terms of screening screening is below that line. If you have a first-degree relative or 2 or more relatives with either breast cancer, colon cancer, those are the women we will screen. But otherwise, the prevalence is too low to screen general population. So in summary, when we are looking at women, the features that we worry about are complex cyst with solid components. If we see Doppler that's central in location, in septations, or we see thick or irregular septations, abnormal amount of free fluid allows us to look for mets. Where are we going to look? In the omentum, peritoneal cavity, or in the periphery of the liver. You know where those tumors spread. And size. Most of them are more than 10 centimeters. Just looking at a few examples here. Very big masses. They have disturbing Doppler flow. Malignant, not surprising, but they're big. You want to see them beforehand. What about this? Septated lesions, both with flow, lots of flow in diastole, okay? You can't tell. They're both going to come out. In the final case here, mural nodules, a lot of ugly-looking stuff there, lots of flow, both benign. So we're certainly not perfect. We're going to overcall. We should overcall because we can't tell. But I hope this gives you something to hang your hat on as far as most lesions we don't worry about. When we are worried, we can look in the ascites for mural implants. We can look for, we showed this case the other day, a met there, and we can see an implant over there. We can see thickened omentum with bowel displaced here. So there's a lot we can look for in addition to just the ovary. And finally, if I have a premenopausal woman and a unilocular, fairly small cyst, I'm going to say it's normal. If it's between 2 and 5 or it looks hemorrhagic, I'm going to get a follow-up. Those are functional when they're over 2.5 centimeters. You might want to give her birth control pills to reset her clock and follow her up at the beginning of the cycle, a couple of cycles later. If something looks like a dermoid, if you're mostly they're premenopausal, but even if postmenopausal, you're probably going to be right, it's a dermoid. If it's unilocular, now we're talking about postmenopausal women, and it's greater than 5 centimeters. If it looks simple, it's probably going to be a benign lesion, but you can't be sure. And if it looks complex like this, if you're going to do follow-up at all, make it short-term follow-up, real short-term, not more than 2 months or so. If it's unchanged, it should come out. And some people would say it should come out with that appearance, primarily in a postmenopausal woman. So fortunately, most ovaries are normal. And again, thank you, Dr. Netter. Thank you, Beryl. I know you're waiting, so we'll continue here. Thank you. Okay, you've been a very patient group. We will save some of our best for the last. Dr. Beryl Benassaroff is going to give us 2 back-to-back talks going back to the fetus. The first one's on anomalies of the CNS and face, and the second is cardiac and thoracic. And Dr. Benassaroff is clinical professor of OB/GYN and radiology, and she shares some of her valuable time with us at the Brigham and Women's Hospital. Thanks, Beryl.
Thank you very much. Is this working? Okay, does anybody want to stretch just for a minute, or should we just keep going? No, keep going. Okay.
Because they only get out an hour for dinner. I'm such a I hate being
well, you are a slave driver, aren't you?
I am terrible. But these guys want to learn everything. All the pearls falling in.
CNS abnormalities of the fetus. Probably one of the most important areas that we have an opportunity to look at for the fetus. Because CNS abnormalities are among the most common major abnormalities of the fetus. And the ones that we're going to go over are listed here, or at least the ones we're going to try and go over during the time that we have. This is a common enough abnormality that 25 years ago, it was added, the MSAFP was added to what every pregnant woman is offered as a blood test for screening. So screening for neural tube defects is now, or has been for at least 20 years, a common and a normal part of prenatal care. And what we look for with the MSAFP, or maternal serum oxygen protein, is the open neural tube defects, which are by far the most common of all the abnormalities here. So let's go through these one by one and take a look at them. First of all, what is the components of the fetal brain evaluation? First of all, you want to look at the shape of the skull. And the shape of the skull can take on various shapes. It can take on as you're familiar with, I'm sure, the lemon sign that we're going to see in a minute, which is associated with an open neural tube defect, and that's sort of a pointy aspect of the frontal portion of the skull. It can also take on bizarre shapes if there's craniosynostosis in the third trimester, and so you may see some acrocephaly, a very high head that is also brachycephalic. So there's all sorts of different shapes that are involved in that. So the head shape is definitely important. You want to locate the lateral ventricles, and that's easy to do because the choroid plexus really represents a marker for the lateral ventricle. So that is the best way to find it. And the position of the choroid plexus within the ventricle describes really the size of the ventricle. It's very, very handy. So when you measure the lateral ventricle, you just follow the location of the choroid plexus. The cave of Septum Pellucidum is a structure which is related to the Corpus Callosum. So the presence of the cave of Septum Pellucidum is very helpful to indicate that the Corpus Callosum is in fact there, and that you can pretty much rule out those forms of abnormalities such as holoprosencephaly, some of the midline abnormality like optic dysplasia and so forth. You want to look at the posterior fossa, configuration of the cerebellum, make sure the vermis is formed, and make sure that there's plenty of space behind the cerebellum for the cisterna magna, but it's not too big either. It has to be less than 10. And so you take a look at the size of the cisterna magna, and then of course you look at the texture of the brain, make sure there's no cysts or masses or anything that produces asymmetry or is abnormal. Early on, at about 7 to 8.5 weeks, which is when this was taken, you can see the developing brain has a cystic area, particularly in the back there, the rhombocephalon. This is a normal part of development. Don't try to call this a Dandy Walker abnormality. This is a normal part of development of the posterior fossa. As development continues, this is at about, say, 14 weeks, and this is about 15 weeks, you see how large the choroid plexus is. And you can, those are those bright echogenic areas in the center, and they essentially fill the lateral ventricle. You can see a little bit of the lateral wall of the lateral ventricle, but basically you can count on the size of the lateral ventricle actually being the same as the size of the choroid plexus, and that's a very handy landmark. And even as early as 10 or 11 weeks, you can already see the faults, and you can already see the choroid plexus. Now, the normal corpus callosum doesn't really finish its formation until about 20 to 21 weeks. So again, don't try to look for it at 14 to 15 weeks because you will not see it. You may see evidence that it's developing in that the cave and septum may be there at 16, 17, or 18 weeks, but you will not be able to demonstrate this kind of corpus callosum at 18 weeks because it just will, the formation of it is incomplete at that time. So patients that come in with a family history of agenesis of the corpus callosum, you want to bring those patients back at no earlier than 20 weeks for the scan. Now here's the cave and septum, you can see it's there, and you can see the lateral, the frontal horns here, and demonstrate the corpus callosum in this way. But most of the time when you're scanning a fetus, you will not get this view unless you're scanning transvaginally on a vertex fetus or unless you have 3D. You will not get these views that we can get, say, in the neonate looking through the fontanelle. Then you can take a look at the posterior fossa, and this is the posterior fossa where you see the lateral, the hemispheres of the cerebellum right here. You can see the triangular-shaped fourth ventricle, which is right there, and the roof of it is the vermis of the cerebellum, which is that bright echogenic area that bridges the two cerebellar hemispheres. Behind it is a fluid collection, which is normal, and which is the cisterna magna. You want to make sure that's there because in an Arnold-Chiari type 2 malformation where the whole thing is sort of pulled down the foramen magnum, this space is obliterated, and that is one of the excellent signs of an open neural tube defect. Now, as the ventricle develops, and we'll spend a little bit more time on the ventricle in a minute, the choroid becomes smaller and smaller with respect to the size of the overall brain. If you remember early on, the choroid took up really the majority of space in the head that we were imaging. And here, in fact, in the third trimester, it is present in only a small portion of the brain, and most of the brain is actually something else, not the corpus, not the choroid plexus. But the choroid plexus still is an excellent marker for where that ventricle is, and we measure the lateral ventricle at the atrium, which is the very end of where the choroid is, and you can measure it. And what's nice about this measurement, it is one of the few measurements, in fact, it may even be the only measurement that is constant throughout the second and third trimester. There is hardly any other measurement in the fetus that is the same throughout gestation in the second and third trimester. So you can measure it. It should be less than 10 millimeters. Typically, it's about 6 or 7 millimeters. You can actually angle a little bit tangentially and see the entire choroid sort of spread out. Of course, that's not a good place to measure it, but it's a good place to observe it, perhaps, if you want. And sometimes the upper ventricle can only be observed this way because of the shadowing that you get from the skull on the coming in the front. So you have to come in through some sort of a suture in order to demonstrate that lateral ventricle. So a lot of times we measure the one at the bottom because we see it better, and then the one on top we sort of angle to get in there. But in here you can see that the choroid does fill the lateral ventricle very nicely, and there's no need to measure it because we know that qualitatively it is normal. Okay, now we'll spend some time on the spine in a little bit. I'm going to stay on the head for now. And we'll talk about the abnormals now. Anencephaly is the most common neural tube defect that forms. The reason we don't hear about it very often is because these fetuses do not survive. This is a lethal abnormality. Fetuses die typically shortly after birth. There is absence of the skull, and therefore absence of the brain, essentially, probably above the midbrain. The brain, in order to form, needs a skull covering, and if it happens to form without the skull, then the brain becomes disorganized and eventually autolyzes within the amniotic fluid. This is almost always picked up early on. It is targeted by the MSAFP and also the sonogram. This should be picked up as early as 10 weeks. There's really absolutely no reason to miss this abnormality because it is pretty severe. Early on, though, sometimes, and this is at about 12 weeks, you can see that the brain has formed in part in this fetus that did not have a skull. You can see the orbits right here with the lenses of the eye. But you can see that there's some brain that has formed, and this may go under the name of acrania. It's basically the same thing, acrania and anencephaly. It ends up with the same prognosis. And a lot of times early on you will see some brain like that, and eventually this will autolyze in the amniotic fluid and become the classic form of anencephaly, which we see later, where the brain really disappears completely, and all you have is the bony orbits and the back of the head as the uppermost portion of this fetus's head. Now, because the fetus is missing practically its entire brain, it will move in a jerky fashion. I think it's probably having just intractable seizures. And not only will it look frog-like, and this is the classic look to it, and sometimes you see echogenic fluid because of the autolyzed brain that is in there. But if you look at the movement that takes place, it's sort of these jerky type of seizure-like activity, which is very common, and these fetuses move more than other fetuses. Now, the syndromes that you might want to think about when you see a fetus with a neural tube defects are listed here. Of course, there are many more than the ones that are listed here, but I just want to bring your attention to a couple of ones. First of all, this can be a result of a teratogen. Valproic acid is a treatment for seizures, and it is a notorious teratogen for neural tube defects. If you take valproic acid, the chances are between 1 and 2% that you could have a neural tube defect, whereas the chances of neural tube defects in the general population is more like 1 per 1,000. Also, when you have a neural tube defect, you have a pretty high incidence of chromosomal abnormalities, so patients who decide to continue their pregnancy or where the neural tube defect is discovered late. An amniocentesis is in order because you may be dealing with more than just a simple neural tube defect, but with a lethal abnormality. Then there's some syndromes such as Metalworker Syndrome, which is an autosomal recessive syndrome. That involves Encephalocele, which is a form of neural tube defect up high, polydactyly and cystic kidneys. That's another lethal abnormality. Amniotic bands can disrupt the spine, can disrupt pretty much any part of the neural tube. And if you look at the spine, you will see these neural tube defects as a lot of times sacs that emanate from the back. But it's very important to also look at the spine and look at the defect within the spine. We'll just show you some examples of that in a minute. The lemon and the banana sign are an important set of signs that were put in the literature now a good long time ago, at least 15 years ago, and are extraordinarily helpful for the detection of neural tube defects. Open spina bifida can be very subtle. Little tiny defects in the sacral region or sacral lumbar region can be very hard to detect. And yet, open neural tube defects almost invariably have signs in the fetal head that indicate that they're there. You can have a lemon sign, which is this sort of lemon-shaped skull, although that can be seen in normal fetuses, so that certainly is not a sign that there's definitely an open neural tube defect. But the fact that the cerebellum wraps around the brainstem like a banana, that is not normal. That can never be normal. And that is definitely an indication that there is a neural tube defect someplace, and you just have to go and find it. And note also that there is obliteration of the cisterna magna behind that curved cerebellum. So really the presence of the head signs has made amniocentesis obsolete for the elevated MSAFP. Back when I started in ultrasound, I won't tell you how many years ago, amniocentesis was always done for patients who have elevated MSAFPs, even a little bit of an elevated MSAFP, because the pickup rate of neural tube defects was only reportedly about 80%. Now I'm glad to say it's much higher than that. And here again is an example of the lemon sign and a very severe banana sign. That's so severe that you can almost get the impression that the cerebellum itself is actually heading down the foramen magnum because of the Arnold-Chiari type 2 malformation. Now, what do these neural tube defects do? It's very important to look at the spine, even if you look at the head and the head looks normal. You can still have certainly closed neural tube defects with skin covering. These are the minority of the neural tube defects, but they can give you a situation where you don't have the head sign. So do definitely look carefully at the spine. And you can see sometimes in these long neural tube defects the widening of the posterior elements here in this very long and severe defect. Now, this is a flat defect, so that if that one doesn't have a big cyst that's hanging off the back, it'll be a little harder to spot in some views. This one has the nice big cyst, so this one's going to be pretty easy to spot, plus a lot of times they do have polyhydramnios, which you can also identify. And here's just a clip showing you what these look like. You should actually look at the spine, look at sometimes a little bit of widening of the posterior elements. You can see the sac, the fluid collection in the back, and you can see the actual hole in the defect itself. So all these things can be appreciated. Here's another one. Now this one, you can see the large sac back here. You can actually see the defect. Whoops, this is not happy. Okay. I'll just bring it up again. That clip's been giving me trouble here. And we're going to go down to, let's see. We'll go down to this one. There we go. Now this one was an interesting one because it shows that you can have a flat defect which is very large, long I should say, and large, but very flat. And if the fetus is breached, you can see how easy it is to miss these back here. And you have the butt of the fetus really right down in the bottom here. Now there is a kyphotic deformity here which should actually make you realize that you've got a humongous neural tube abnormality here. But it is very easy to overlook those, particularly if the fetus is not in a good position. Now, this was a patient that we saw, had a new sonographer. This was years ago. A new sonographer on her first day brought me this case to review before I went in to check it. And this was her BPD. So I said to the sonographer, I said, "Oh, did you find a neural tube defect?" She said, "No, I didn't. This is a normal case." And I said, "But I know there's a neural tube defect here because there's a lemon and there's a beautiful banana. In fact, I've rarely seen such a nice banana sign as the one that she actually photographed. This is it." And she said, "But this is my picture of the spine, and the spine looked fine." Well, you got to look some more because you cannot walk away from this case. And so you can use the transvaginal probe and take a look and find this little itty-bitty hole here in the spine that would account for this banana and lemon sign. So the workup for the neural tube defect needs to be an amniocentesis if the patient is going to continue her pregnancy, because in this particular study, 17% of the fetuses with neural tube defects had an abnormal karyotype. So, and some of these had isolated spina bifida. So even with isolated spina bifida, there is a very high incidence of abnormal karyotypes, such as trisomies 13 and 18. So you need to look for that. Now, an encephalocele is a neural tube abnormality, very high up, obviously. It's an opening, but it involves the skull as opposed to the spine. The higher your neural tube abnormality is, the more severe the outcome is, or the worse the outcome, and the more severe the handicaps. These are some of the syndromes that are associated with encephaloceles. The number one syndrome, obviously, is the Metalworker Syndrome, which I told you was the autosomal recessive syndrome where you have polydactyly and cystic kidneys. You can also have trisomy 13, which can also have polydactyly and cystic kidneys, so that can be a mimicker of Metalworker syndrome. Then you have Walker-Warburg syndrome, which is one of the lissencephaly or smooth brain syndromes, very severe mental retardation here. You can have an encephalocele together with a Dandy-Walker abnormality, where the Dandy-Walker is actually out in the encephalocele, and I'll show you an example of that. The head can be disrupted by amniotic bands. A lot of times you will get microcephaly when you have an encephalocele, because if some of the brain is outside of the head, then the head itself is going to be small. It's not going to be large enough. And then you have some clefts, facial clefts that are associated with encephaloceles as well. And this is an example of an encephalocele with, you can see the encephalocele back here. There's a Dandy-Walker abnormality as well. In fact, what's out there is probably part of the fourth ventricle. You can also see that there's ventricular megillah here, and then you can see that there's a large third ventricle, high riding, so there's also agenesis of the corpus callosum. So all these things are present in this fetus. Here's a fetus with amniotic band syndrome, and you can see that, first of all, these amniotic bands are coming right into the head. This is a coronal view of the head, and here is an encephalocele. But this encephalocele is asymmetrical. It's sort of coming off to one side, in a sense. And that doesn't make embryologic sense, if you will. And the things that don't make embryologic sense, you can think about amniotic bands. Because amniotic bands is an injury. It's not something that's going to happen embryologically necessarily. It's a direct injury to the fetus, so it doesn't have to follow the usual rules. And here is an arm and an absent radial ray with a sort of partly amputated hand, also part of amniotic band syndrome in the same fetus. Now here's another fetus whose head is all mangled up here. You can see that there's a severe encephalocele up front. There's something going on back here. This is the only part of the brain that's really still not cystic, and that's abnormal as well. This was another case of amniotic bands. The things that don't make any sense like this are usually amniotic bands because of the injury aspect of it. Here's an encephalocele that is very large. Here's the transverse and the longitudinal view, showing that this is such a large encephalocele that most of the brain is actually outside rather than inside. You see the choroid plexus, you can see the lateral ventricles, all outside the brain. This has a terrible prognosis. This fetus will probably not survive despite any kind of treatment that might be available. Here's another one that's just as big. Now, here is the head. Now, you can see why These are associated with microcephaly because the head is very small because most of the brain is out here. And this is a longitudinal view done transvaginally, actually showing you the texture of the brain that's outside. This is the skull, and this is the large opening back here in the posterior aspect, letting all this brain come out. Encephaloceles are mostly posterior and occipital, but occasionally they can be anterior. Here's an anterior one, bulging on the front, and this is a view of sort of the front or the profile of the fetus, showing this bulge out in front. These are much more unusual. They can be associated with clefts and other types of syndromes. Now, this is a fetus that came in at about 8.5, 9 weeks, and as a routine size and dates. And there were two things here that bothered me. First of all, the rhombocephalon, which is normally cystic, was a little bit too big for the size of this fetus. And there was also a bump on the back here that really was not normal. This should be nice and smooth. There should not be that bump on the back. So we brought this patient back at about 11 weeks. And sure enough, if you look at this image, you can see that this bump has become bigger, and the cystic area is within the bump. So this is a Dandy-Walker abnormality with an encephalocele as well. Now we know that one of the syndromes that can do this is Meckel-Gruber syndrome, which is associated with the cystic kidneys and the polydactyly. So went looking for this and found, in fact, at 11 weeks that this fetus had extra digits and had these cystic kidneys. So you can nail down these diagnoses if you know what you're looking for early on, even in patients who don't have any family history. Now, ventricular megillah obviously denotes ventricles that are too large, and you need to determine, first of all, this is an isolated finding, or is it associated with lots of other abnormalities? These are some of the syndromes that are associated with it. The smooth brain syndromes, or lissencephaly syndromes, of which there are two, Miller-Dieker syndrome and Walker-Warburg syndrome, are invariably associated with some degree of ventricular megillah. A lot of times, agenesis of the corpus callosum is also associated with it. Down syndrome can be associated with ventricular megillah, usually mild. And there's a number of other syndromes. Now, this one is not isolated. This one has a Dandy-Walker abnormality, and you can see the posterior fossa here. The cerebellar hemispheres are these little guys right here that are plastered up against the tent. And this is a large dilatation of the fourth ventricle that is filling the rest of the posterior fossa. This is very typical of Dandy-Walker abnormality. Now, we measure the ventricular size, as I told you before, at the level at the end of the choroid plexus, at the level of the atrium, and that is a pretty constant measurement. You can also eyeball it and see that the choroid is drooping down and obeys the laws of gravity by drooping down towards the bottom. And it will very conveniently point you to the lateral wall of the lateral ventricle. So it is very convenient as a marker. And you can take a look at this and suspect very strongly that the ventricles here are too big. You throw calipers on it, and sure enough, it is. But you can see that the choroids are very convenient in they show exactly where to put your calipers. Here, they're both actually hanging down the same side, which is unusual. But it is a great marker to know exactly where to measure. Now, one of the few places where I would recommend an MRI is intracranial abnormality, particularly ventricular megillah. The MRIs can be helpful to detect some of the causes of ventricular megillah and some of the disturbances in brain formation which escape the detection by ultrasound. Now, what happens with borderline ventricular megillah? What if you throw your calipers on and it measures 10 or 11? Are you going to sort of squeak by and tell the patient that the baby's fine, or are you going to say, well, the baby has hydrocephalus? And that's a big difference, at least for the patient, is going to make an enormous amount of difference. So there have been actually a number of articles that have looked at what to do when the ventricle measures 10 to 12 millimeters, because it is something that comes up, and we're very tough as you're looking at these parents who are absolutely delighted to have this baby, and you're about to tell them something that's going to devastate them and probably ruin the rest of the pregnancy for them. So if the lateral ventricles are greater than or 10 to 12 millimeters, there have been some studies that have shown that the prognosis is better, much better, than if it's a severe ventricular megillah. We did our own study, which I'll share with you in a moment. But when you have borderline ventricles, first of all, make sure that there's not agenesis of the corpus callosum, because that's a lot of times the explanation for borderline ventricles. And take a look, find the corpus callosum or the lack thereof, even if you have to do a transvaginal scan and get right on top of the fontanelle to show it to you. Even if you don't do a vaginal scan, you can suspect agenesis of the corpus callosum. It is a very subtle abnormality early on. But if you look at this case here, you'll see, first of all, that the lateral ventricles are parallel and that there is no cavum septum. And in fact, if there were a cavum septum, it would be too big. It would be too wide. And you need to sort of memorize this appearance, and this appearance where the cavum septum is not there, and even if it were there, it would be much too wide. There is too much space in between here. The shape of the lateral ventricle is also a little bit of a colpocephaly type of shape, or a teardrop, but it's really the space between the frontal horns that sort of nails it. Here's another one. Again, the shape of the frontal horns, the space between it, which is too big, and the teardrop appearance of the lateral ventricles, and the MRI will also demonstrate the same thing. So, Vendee-Walker complex. Okay, what is Vendee-Walker complex? It's basically a cyst in the posterior fossa. It's too much fluid in the posterior fossa. There are really three types of things that you can call that. First of all, the classic Vendee-Walker cyst, which I showed you on a previous slide, which is basically the fourth ventricle just forms a big cyst because the cerebellum vermis just doesn't form. And then the cerebellar hemispheres are these little teeny-weeny things that are just pushed over to the side, and you can see it here as well. Vendee-Walker variant, the Vermian hypoplasia, less severe. It's mostly inferior Vermian agenesis, and the cerebellar hemispheres are actually almost normal size. They can be a little bit small, but they're not half as small as they are in the full-blown syndrome. And then the megacisterna magna is simply a slightly wider cisterna magna than normal, but the cerebellum and vermis are normal. And that tends most of the time to be a normal variant, although you really have to look very carefully at the fetus for any other findings. This is a Vendee-Walker cyst. You can see the cystic area behind the cerebellum. This was sort of interesting. We thought this was a Vendee-Walker cyst, but you can see that the epicenter of this cyst is actually over to one side. It's not central. It's not symmetrical. And that should have been a tip-off that this, in fact, was an arachnoid cyst in the posterior fossa. So the vermis is there. You can't really see it in this picture, but things are pushed over by a cyst that originates from this area rather than splayed apart by a very large fourth ventricle. This is the Vendee-Walker variant, and you can see two different cases. This is the cerebellar hemisphere on one side, the other side. This is that little keyhole connection between the fourth ventricle and the cisterna magna by the inferior vermis that does not form or does not close. And here is a similar case. Slightly smaller cerebellar hemispheres, but still they do sort of meet in the middle. And so it's not a Vendee-Walker cyst full-blown. And this is, again, a Vendee-Walker variant showing, actually it's more like a Vendee-Walker cyst because you have that cyst coming out in the back, and you also have agenesis of the corpus callosum. Now beware of calling Vendee-Walker abnormalities too soon. Here is one that we saw at 14 weeks, and we called it Vendee-Walker abnormality at that time, even convinced the patient to have an amniocentesis. She came back at 18 weeks, and it was completely normal. And we were starting with a new machine here, and we were seeing things extra well and scanning transvaginally. We had 3 of these in one day. So I figured, well, something's going on. I went back to the embryology books, Moore's embryology, and that it says there that the vermis doesn't finish forming until 16 to 17 weeks. So do not look for items that have not formed, because they won't be there. And we actually did a little study to look at when, in fact, the cerebellum is visible by ultrasound, or the vermis is visible by ultrasound. And we looked at fetuses that were undergoing amniocentesis between 13 and a half and 21 weeks, and we found that the majority of 13 to 14 weekers had open cerebellar vermises. And then they closed gradually until by 18 weeks they're all closed. These were all normal fetuses. So if you're worried at 15 weeks, 14, 15 weeks, somebody coming in for an amnio perhaps, and you see a little keyhole business, just say, well, we're not seeing the cerebellum really well, come back for a full survey at 18 weeks, and that's perfectly acceptable. And I would not even mention the word Dandy Walker if you're going to scare the patient half out of her wits, and it's not really fair. So, now let's look at masses in the brain. Echogenic masses in the brain. What is echogenic by ultrasound? Not a whole lot of things. There's really not a lot, okay? There's blood. There's fresh blood. And this is a fresh bleed in the parenchyma of this fetal brain. There's fat. Fat is echogenic. This is a lipoma of the corpus callosum right above the level of the third ventricle right here, usually associated with agenesis of the corpus callosum. Calcium is another one that's bright, and this is a whole bunch of calcium that is deposited in the brain of a fetus that had a viral infection and will invariably have microcephaly and severe mental retardation. And tumor. This is a large teratoma that is filling the entire brain. This is very bad news. These are highly destructive, and no survivors with that. So let's look at some examples here. This is an intracranial bleed. The fresh bleeds tend to be very echogenic like that. As they start to organize, you see some more cystic portions of the bleed with low-level echo, sort of like one of the endometriomas that Dr. Lang showed you a minute ago. And as you go further, you see that appearance of that low-level echoes in sort of non-clotted blood in this very dilated ventricle now where there's been a huge bleed. And here is a clip showing you that acute bleed in this fetus. And this is actually one of the most interesting cases I've ever seen. This goes back a long, long time now. This patient came in just for a routine sizing, and the entire brain was bright. The entire thing was bright, except for the thalami. And we didn't know what we were dealing with. Turns out that this was hydranencephaly. The patient came back a few weeks later, and the entire brain was liquefied. And basically what happens is that there is some sort of occlusion of the carotid arteries bilaterally. The entire brain infarcts, except for the midbrain and brainstem. And so you have complete liquefaction of the brain. And you see it go through the process of being very bright, like an acute bleed, and then going through the process of being completely liquid. This is another case of lipoma of the corpus callosum. They are absolutely pathognomonic. There is nothing else that's going to sit in the center of the brain. Very symmetrical, very bright. Sometimes have these little extensions and little antennae here. But in any case, this is a lipoma, and there's really essentially nothing else that will do that. Cytomegalovirus or other types of virus will give you the bright sort of lining to the lateral ventricle. Sometimes it's the lining like that. Sometimes it's like golf ball type of, or little golf ball types of increased echogenicity. You can also have ventricular megillah associated with viral infections. These are very bad news. Here's another viral infection. This was sort of interesting. This is transabdominally in a rather heavy lady. You could see the deposits of calcium, but it was not periventricular. It was a little further deep in the brain. And the reason that I can tell you that this was not the ventricles is because that's not where the choroid plexus is. The choroid plexus is always a great place to look for what the confines of the lateral ventricles is. And here is the choroid plexus right here. It does not go all the way out here, so this is not the ventricle. You can see exactly where that choroid is. There is no ventricular megillah right now in this fetus. What there is, though, is a ton of calcium in the brain parenchyma throughout. This fetus developed severe microcephaly. Didn't do well at all. This is another the cytomegalovirus, with these, in this case, calcification, areas of calcifications throughout the brain, and also very abnormal cerebellum, smaller one hemisphere than another, very severe abnormality. Now, when you have viral infections like toxoplasmosis, you can also look for cataracts. And here's a fetus that had a cataract. You can see the cataract right here, and I'll show you a close-up of the same fetus. This is a cataract right there within the lens. Intracranial fluid collection, there can be different types. The two main ones that I want to bring to your attention, porencephaly, which is basically a brain-destructive type of abnormality where there is a cyst that develops that communicates with the lateral ventricles, and in this case, the lateral ventricle is dilated, the choroid is hanging down, never reaches the lateral wall because that's missing because of a large porencephalic cyst. Compare that to the arachnoid cyst, which may cause some ventricular megillah because of pressure, but it is not connecting with the lateral ventricles at all. It is really separate and can be shunted separately. When the arachnoid cyst happens along the falx, and it's called an interhemispheric cyst, it's invariably associated with genesis of the corpus callosum. Here are two different cases. And when you see the cyst in between here, and then in between there, you can count on there being a genesis of the corpus callosum. You won't see it because this sits right where the corpus callosum is supposed to be, but you know that the corpus callosum is missing. I'm just going to pass due to time here and just show you this other cyst right here. This may look like an arachnoid cyst and could be mistaken for an arachnoid cyst, but what should we always do here? Color, absolutely. This is an AVM or a vein of Galen aneurysm. These are devastating. Fetuses die that have this. They go into severe heart failure. You don't even have to use color sometimes. If you see the vein connecting, you can just look at it in real time. Okay, the last area to go into is holoprosencephaly. This is a devastating brain abnormality, at least the alobar holoprosencephaly. You have an absence of the falx, so you have the central monoventricle. You have fused thalami with absence of the third ventricle, and a very severe, obviously, abnormality. They are invariably associated with severe facial abnormalities as well. They can have hypotelorism, eyes are very close together. They can have terrible facial clefts. You can see how these thalami are fused into one without any third ventricle in between. This is actually a case that had not only a holoprosencephaly here with fused thalami and a central orbit, this is Cyclops here, but also a banana sign. So now we've got two things. We've got a banana sign, so we've got a neural tube defect, which ended up being here. We have to look for it. But we also have holoprosencephaly. This fetus had trisomy 13. And the type of facial abnormality it had was that central orbit cyclopia, which if you turn the fetus to its side, you can see the proboscis that comes out in front here. Very abnormal. The types of clefts that are associated with holoprosencephaly are very severe central clefts. We can also have clefts that are associated with lots of other syndrome, which we really don't have time to go into, but I'll just show you a couple of examples. This is a midline complete cleft lip and palate. Both fetuses, two different fetuses, have a bilateral cleft lip and palate. This is a bilateral cleft lip and palate, just to show you what it looks like. It is not subtle. It is actually fairly easy to see, and just a clip to show you what that looks like. Okay, I'm going to stop here, and I'm going to switch gears because I'm out of time here, and give you just a moment to sort of stretch for a second while I go on to the next thing.